In the oliguric phase of acute renal failure caused by ATN, expect to find a blood sodium level below 135 milliequivalents per liter, indicating hyponatremia. A blood potassium level above 4.5 milliequivalents per liter, indicating hyperkalemia. A BUN level above 20 milligrams per deciliter, and a creatinine level above 1.2 milligrams per deciliter, indicating azotemia. In the diuretic phase, watch for the blood potassium level to fall, as potassium is excreted in the urine. Expect urine tests to reveal low osmolality of dilute urine, indicating the tubule's inability to concentrate urine. An elevated sodium level, reflecting sodium loss in urine. And sediment that contains red blood cells and casts, reflecting blood cell leakage through damaged glomeruli and tubules. Also, anticipate finding protein in the urine. Proteinuria occurs when damaged glomerular capillaries let large protein molecules pass through to the urine. If the cause of renal failure is unknown, prepare your patient for other tests, such as a renal scan. During a renal scan, a radioisotope is injected into the blood. Then the kidneys are visualized through a scanner. A renal scan may show abnormal kidney structures, which may occur in renal infarction, abnormal perfusion, which may occur in renal artery atherosclerosis, or abnormal excretory function, which may occur in ATN. After acute renal failure is confirmed,
Okay, let's take a look at the severity of classification of acute kidney injury. This is in a table in your book. Now that says 47.3. I'm going to look here real quick because you haven't, yes, that's the right table, 47.3. And RIFLE is the acronym, RIFLE, risk, injury, failure, loss, and then end-stage kidney disease. In risk, you have serum creatinine that's increased or the GFR is decreased by 25%. In injury, you have serum creatinine that's twice the normal value or the GFR has gone down by 50%. There's also urine criteria that goes with these. In failure, serum creatinine's gone up 3 times or GFR has gone down by 75%, or you've got a serum creatinine of greater than 4, or you have an acute rise of more than half a milligram per deciliter. Now that's something to think about. When you're looking at creatinines, small changes mean something. So a creatinine that was 1 and suddenly jumps to 1.5, that needs to be paid attention to. In loss, there's persistent acute kidney failure. The kidney function is still completely gone, even greater than 4 weeks out. And end-stage kidney disease is identified when the kidney function does not return to normal. There is complete loss of kidney function for greater than 3 months. Now, if we look at phases, the video discussed the oliguric phase, the diuretic phase, the recovery phase, but as I looked at that, it kind of gave you the idea that that all happens in a day. Excuse me, it doesn't. In the oliguric phase, you have low urine output. This phase usually begins anywhere from 1 to 7 days after the insult. The average duration of the oliguric phase is 10 to 14 days. So during that time, we have to be concerned about that patient having fluid volume excess, having an excess of potassium. The things that the kidneys normally clear are excessed. Now in the diuretic phase, the urine output starts to increase, and the patient may lose loads and loads and loads of water. Now, what you need to realize is when the kidneys are losing or excreting, actually it's more like losing, lots of water, electrolytes are going with it. So in the diuretic phase, you have to be very concerned about hyponatremia and hypokalemia. The average duration of the diuretic phase is 3 weeks. And during this phase, there can be, up to 4 to 6 liters per day of loss. And then recovery occurs, is kind of an ongoing thing. Most of the improvement occurs in the first 2 weeks, but renal function can improve for up to 12 months. Now, do not confuse phases and causes. Causes of kidney failure can include pre-renal situations that are not corrected, post-renal situations that are not corrected, or intrarenal conditions that occur. Okay? So just because someone has oliguria due to dehydration, that is not the same as the oliguric phase of acute kidney injury. When we're talking about the phases of acute kidney injury, we are looking at a situation typically where the kidney proper has been damaged, whether from a pre-renal or a post-renal, but those conditions have been allowed to continue and the kidney itself has experienced damage. So you see low urine output, fluid retention, and you see metabolic acidosis. The metabolic acidosis happens because the epithelium doesn't synthesize ammonia. You get excess hydrogen that accumulates. You get an exhaustion of bicarbonate supply. And then that metabolic acidosis, because it is acute, can produce the Kussmaul's respirations as the body seeks to eliminate acids in a different way. You also can expect hyperkalemia in the oliguric phase because the kidneys are responsible for eliminating 80 to 90% of your potassium that is in excess of what you need. Azotemia can produce lethargy and confusion. You might see elevations in phosphate and low calciums, although in acute kidney failure, this is not as much of a problem as it is for someone who has chronic kidney disease. In acute kidney injury, we look at the phosphate and the hypocalcemia in terms of the functions of those electrolytes. In chronic kidney disease, the bigger problem is the impact that these substances have on screwing up the bones and producing renal osteodystrophy. You do not see renal osteodystrophy in acute kidney injury. Another thing about kidney failure in general, because kidney failure produces a metabolic acidosis, symptomatic hypocalcemia is uncommon. Acidosis keeps more of the calcium in its ionized state. The ionized state is what's floating around in your body. It is what minimizes symptoms. In a normal acid base with normal albumin, about half of the total calcium is bound to albumin, but when you become acidotic, then more of the calcium is released. All right, as we progress from the oliguric phase, where you have to watch the potassium, be concerned about water excess, heart failure, oxygenation issues because of too much water in the lungs. As you progress through the process of kidney failure, the patient moves into the diuretic phase. Here you have urine output that goes up because the tubules can't concentrate, and also because of an osmotic diuresis from the bun being elevated. The diuresis can be so pronounced that the patient can become dehydrated. Hyperkalemia can produce abnormal heart rhythm, but so can hypokalemia. Hyponatremia can also occur because as the kidneys are diuresing, they're losing lots and lots of sodium. They cannot hold on to the sodium as they should. And so you have hyponatremia. The azotemia and uremia starts to resolve later in this diuretic phase. So initially in the diuretic phase, bun and creatinine may stay elevated, but as the patient moves through this diuretic phase, the azotemia and uremia, the bun and creatinine decrease to baseline or it kind of plateaus out. Now, just to give you an idea, the video did say that urine output can be in excess of 400 milliliters per hour. That's a lot of water. The recovery phase begins 3 to 4 weeks after injury. Recovery continues for up to a year. The patient might have some residual renal insufficiency. However, that's not usually a problem because we've got lots of renal reserve. It should be noted, though, that patients who have insufficiency are going to be vulnerable to additional renal injury because their reserves have been impacted. All right, blood and urine tests in acute kidney injury. During the oliguric phase when you're not making urine, again, do not mix up the oliguric phase of acute kidney injury with prerenal oliguria. One is cause, the other is phase. We're talking about phases. We're talking about what people go through who experience acute kidney injury, regardless of the cause. So in the oliguric phase, you see a fluid volume excess that dilutes out the sodium. Their total body sodium is probably elevated, but it's watered down. You see elevations in potassium and you see azotemia. In the diuretic phase, the kidneys cannot conserve electrolytes. So you see hyponatremia and hypokalemia in particular. You may have to replace potassium and you most certainly will have to replace fluids. Think about how much water is being lost at a rate of 400 milliliters an hour. Well, in 10 hours, that's 4 liters, right? Add another 0. In a day, that's, well, in 20 hours, that would be 8 liters. So 8 liters. Think about a gallon. A gallon is about 4 liters. So, 2 to 3 gallons of urine lost in a day. That's a lot of water. Now the urine will be low osmolality, elevated sodium. That's because this is not, the body's broken, the kidneys are broken, low osmolality, sodium in the urine is high. There may be sediment and protein in the urine. The diagnostics were mentioned in the DVD presentation. You may see a renal scan to identify some kind of structural problem. This is an old picture that I had, but it's pretty helpful. I mark out failure. So you have prerenal oliguria or prerenal causes, and those involve heart and circulation to the kidneys. You have postrenal oliguria or postrenal causes. Those are obstructive things. And if this or this is allowed to continue and is not fixed, then those things can actually damage the kidneys proper, and that would be one more reason why you may have actual parenchymal failure. Now, in addition to prerenal and postrenal causes of parenchymal failure, you can also have other conditions like a medication that damages the kidneys, even though the